Terrific. Well, we're going to go ahead and get started. Good evening, everyone, and thank you so much for joining us today. We're really excited for this conversation, and I think it will really be an incredible discussion. I think it'll be very revealing for those of us listening in, and really enlightening. So as you probably know, if you're joining us, that this is part 3 in a 4-part series that Deep Connections is doing in conjunction with the LGS Foundation. If you have not seen parts 1 and 2, please check them out. Really an exciting progression that we have going here. The first being an overview about the research and more generally about kind of rescue meds. The second with a fantastic pediatric neurologist talking more in depth about different kinds of rescue meds and how they're used, and sharing some of his guidance. And then this, of course, is number 3, where we're going to be hearing from a panel of DEE caregivers about their experiences with rescue meds and seizure plans. So a quick couple of housekeeping notes. All of the people who are, all the participants are muted and off video. Just the panelists will be shown. This is being recorded and will be available online in a couple of days. And yeah, if you have any questions throughout, please put them into the Q&A or the chat box. And you know, if they're part of, if they are relevant to the conversation, we'll kind of pick it up right then. Otherwise, we'll have some time at the end of the webinar for Q&A. I also just want to say a quick thank you to both UCB and Norellis, who gave us some sponsorship for this series. We're really grateful for them helping us make this discussion happen. Terrific. So I'm going to go ahead, and this is going to kind of be a little bit more of a conversation, a little bit of a different kind of setup. So everyone's going to kind of go around, introduce themselves and their child, and tell us a little bit about what their experiences are. So I'm just going to go around how it comes up on my screen here. Jen, did you want to say anything before we get started?
Thank you.
You're welcome.
Just hello and welcome to everybody. We're doing this in partnership. I'm Jennifer Griffin. I'm with the LGS Foundation, and we're partnering with Deep Connections on this. And so I'm just really, I really appreciate everybody for giving your time today to participate in this panel. And afterwards, of course, it is recorded, so it will be on both the Deep Connections and the LGS Foundation websites. And thank you, Gabi.
And of course, I always forget to introduce myself because I'm looking at so many familiar faces. But for those of you who don't know me, I'm Gabi Conacher. I'm president and co-founder of Wishes for Elliot and Deep Connections. So, okay, so I'm going to go around now. All right, Elizabeth, do you want to introduce yourself and tell us a little bit?
Sure. My name's Elizabeth Terry, and my daughter Spencer is 15. She wasn't diagnosed with LGS until she was 7. So those early years were just really dark. And the positive thing about that diagnosis was the LGS Foundation and all of its resources and support. So that was a huge blessing. We've been really lucky all these years to only have to administer rescue meds maybe twice her whole life. But since the first of the year, right around the time she turned 15, I was just counting up. I've had to give rescue meds 19 times. So her seizures have grown worse, and she's just sort of in a rough patch right now. So I've become very familiar with rescue meds.
Thanks so much, Elizabeth. Kaylee?
Yeah, hi. My name is Kaylee Keene. My son Dylan is 12 and he has Lennox-Gastaut syndrome. So Dylan actually experienced a stroke in utero. So he has had seizures from the day he was born. It's just been consistent and ramped up as time went on. We've had to use multiple types of medications, and we have, I think, a unique approach to his seizures because he has multiple types of seizures.
Thanks. Yeah, and we're going to hear a little bit more of that later on because that's really interesting. Stacy.
Hi there. My name is Stacy Bardick. I live in Parrish, Florida, and I have a daughter, Amanda, who will be 15 in October. And Amanda was born at 9 months old, developmentally delayed, low motor skills, all sorts of things, diagnosed with autism at 2.5, started having her seizures at 5, and we've been on the roller coaster ever since. And I wish I could say for most of her life we've only done rescue meds twice, but that's not the case. But let's see. One thing I love about my daughter is she's very snuggly, and she's a happy girl, and she brings a lot of joy to our family, even though at times we don't know it. But she's a happy, healthy girl, aside from all the other stuff. And she was diagnosed with SCN2A mutation just a couple of years ago, a rare genetic disorder.
Thank you. Yeah.
So we got that.
Yeah.
Mm.
Okay. Hey, Shanna, you want to go ahead? Sorry if I cut out.
Sure. My name is Shanna Talbert, and I live outside of Atlanta with my husband, Terry, and our 2 daughters. The oldest girl, her name is Ireland, and she has a CAC-NA1A genetic variant. She started having seizures at 6 months old, and so they ordered genetic testing, and the CAC-NA1A came back, and because of how she presents clinically, she also has a Dravet syndrome diagnosis. We use rescue meds about once a week at this point, and she has a cocktail, which I can talk more about later. So I'm unfortunately very experienced with rescue meds. They start as focal seizures and they immediately generalize, and she goes into status, and that's her only seizure type is status. So I don't know if that's unique or not, but sometimes it seems like it is. She is a little bit of a party girl. She loves tea parties and she loves to attend birthday parties. She loves anything that goes fast. We look forward to the fall every year because she loves to go to the fair and do the little kiddie rides. And so she too, like all of your children, brings us a lot of joy in spite of all of the challenges that we face.
Thanks so much. Emily?
Hi, I'm Emily Bell with the Bow Foundation. My daughter Madeleine is 5, and Madeleine has a GNAL1 gene mutation that causes severe movements and epilepsy. Madeleine has suffered from seizures since birth, and she mostly suffers from partial complex or focal seizures that tend to cluster a lot. So we have switched medications a lot over the years to try to gain better management, which I'm sure a lot of you can relate to. But in that time, when she experiences a lot of clustering, we have had to utilize rescue medication. But as some of the other ladies mentioned, our kids are not just patients. They are our little angels, and Madeleine loves light up music, lots of lights. And it's, a lot of fun. Nothing's better than seeing her smile, as I'm sure a lot of you can relate to.
Absolutely. Well, thank you so much. I'm so excited that we have such a variety of parents here to help us understand, the DE experience, which frankly is different for almost everyone, it seems like. So there's not a lot of uniformity, but I think it'll be really valuable for us today during this conversation to really hear about that variation and lived experience, the importance of having a plan, and then also really just, becoming empowered to really ensure that your child has all the safety nets in place that they need. So we're going to go through and just kind of take one question at a time, and a couple of people will answer. So the first one is, I want to talk a little bit about the administration of rescue meds. And I should mention too as well that these, all of these parents have been involved in doing a kind of an in-depth interview around seizure meds and rescue plans and all of that, so that we can try to get a better understanding. So we know that all of these caregivers have really a lot of experience. So first of all, let's talk about administration and success of rescue meds. So if you have a clear sense of triggers, what those are, do you adapt based on the trigger, like how long they last or anything like that? And then have your triggers changed over time? So something around there. Do you have triggers? Do the rescue meds work? So Kaylee, why don't you talk to us a little bit about what things look like with Dylan?
Yeah, so I said Dylan, he experiences multiple seizure types. His most problematic seizure type is atonic or drop attacks. So with us, those could come sometimes 100 times a day when he was at his worst. And a lot of times we would see clusters for those. So generally for something like that, we would try and intervene initially with something that's non-invasive. He's almost a teenager and he's in a public school setting. So usually we would start with an oral medication. And if we had to ramp up to like diazepam, which is rectal, what we have at home.
And how effective are the rescue meds for Dylan?
It's hit or miss on the clonazepam. Sometimes that seems to help, and then other times it's just not enough to do what he needs. But then on the other hand, if you're going to give him diazepam, that's probably going to knock him out the rest of the day. So it really is, I guess, a call of how bad is he seizuring, or is it going to alter the quality of life, what's going on, and do we need to intervene, or can we prolong things? Or it's very individualized, very based on what's happening in that particular circumstance.
And you mentioned too that you have different kinds of seizures and different kinds of rescues for different seizures. Maybe you can tell us a little bit about.
Sure. So like generally with the tonic-clonics, we would start with the clonazepam, and then work our way up to diazepam. Now, if he is going in tonic-clonics, did I say that a second ago? Did I mess that up? It's the atonics, we would use clonazepam. And then if he's going to a tonic-clonic, we would administer diazepam within usually 3 minutes would be kind of our point. Because he has a history of going into status, and we kind of know that right off the bat. If things aren't slowing down or he's not starting to come out of it, we know ahead of time that this is the route we have to go, or we're going to end up in the emergency room.
Excellent, thank you. That's really interesting. Stacy, what about you? With Amanda and triggers and rescue meds.
Well, for when she first started having seizures, when she was 5, for a few years actually, they were really all different types. They were absentia, focal motor, petit mal, whatever, I have to admit, I'm not hip to what they're calling it now these days. But then as she got older, they changed. And as well, the triggers changed. Initially, we thought her triggers were heat, being out in the heat too long. For a long time, probably up until 2011, 2012, she was having seizures outside, but she's fallen into pools, and she's had seizures in the ocean when we've been at the beach. It's really scary. But we thought that was a trigger, and she wouldn't have what she has now, which is her tonic-clonics. They kind of evolved. So we think now her trigger, and I think this is really her only trigger, would be sleep. Her cycling through her sleep, we've noticed, again, over the last 6-7 years, that's changed. It's happened with, she's either seized after maybe 20 minutes she's gone to sleep, or early in the morning, maybe a little bit before awakening. She's had very rarely in the middle of the night. It's only during those two times, and they've turned into really severe tonic-clonic. She seizes, well, before Epidiolex, we can probably talk about that later, she could seize 18 times a month with terrible tonic-clonics, and a few times she had actually just stopped in the middle of what she was doing with her iPad, and she'd fall to the ground, and she'd have her go into her tonic-clonic on the floor, which, But regardless, we have had to change the medication we give her, and we've had to really watch her closely. We use clonazepam at first, like you, Kaylee. And a lot of times we get our finger bit because we'd have to stick it in and, you know, between the gum and the cheek. But now, honestly, we strictly stick with Diastat, with diazepam. She goes to a special school, and like your boy also, Kaylee, your boy, I think, right? Yeah, nobody wants that undignified aspect of having a rectal medication administered. But Amanda's in a very special small school, and they're able to do that. She's with females and different situations, so that's what we have to do.
Yeah.
Mm-hmm.
And it typically works pretty well when you it breaks.
Well, yeah. When we had given the clonazepam, that would take too long.
Right.
We were afraid to do the Diastat, but then finally, eventually, it came time. No, the clonazepam's just not cutting it, and we need something stronger and quicker, because she obviously, and I'm sure all your kiddos have had horrible seizures, and you know what they're like. So Diastat, pretty quickly.
Yeah, no, sleep is certainly a trigger for my kiddo Elliot as well. It's kind of in that deep sleep.
Yes.
Yeah. And okay, Elizabeth.
Well, my daughter Spencer's seizures were varied, all different kinds, until she was 10. And then when she was 10, it's almost exclusively now the generalized tonic-clonic. And they last anywhere from 3 to 4.5 minutes. So we're always pushing that 5-minute edge. And same story here, the clonazepam just is kind of a joke. It just doesn't, it never really did work, even though I kept thinking it, at one point it will. And then the diazepam, the rectal syringe that I used as well, that would make her manic for hours, just crazy manic. And so that quality of life that you were talking about, Kaylee, you're actually sitting there thinking, which is worse, you know, the seizures. So, and what I didn't mention during my introduction is having to give so many rescue meds since the beginning of this year is because she started clustering. So these longer tonic-clonics were clustering in the night. So we've had a lot of sleepless nights. I know we all do. And so we have since moved to the nasal midazolam. And so that's been a really great thing to administer, obviously. And the majority of the time it works. But, you know, sometimes it doesn't. And I'm still figuring out, do I give a second dose? You know, it's so new. I'm still working on that with her doctor.
Mm-hmm. Excellent. And has anybody else used the nasal? Not yet. Yeah, us either, although I'm anxious to get it. I mean, there's the time it takes to get down the pants and lube up and all that. So, and apparently it works faster. So
it does. It works well. It did burn her nose at first, like it was bleeding. Oh, wow. And you can see her eyes, but I think her little nose is adjusted to it. So, okay. You know, nothing's perfect.
Right. No, that's a good point to make, so people don't get scared. I mean, you have to figure out what your kid can tolerate, right? So, great. All right. Unless anybody has anything else to add about kind of success rates with rescue meds, with administration, I think we'll move on to the next part, which is finding out, what do people do if the first one fails, right? And I think most of us have been in that situation. And, you know, it'd be interesting to hear like what your triggers are for, you know, maybe if your first round, I know some people give the rescue meds right away because they know it's always like, you know, Shanna, it's always status epilepticus. So, right. So I guess, yeah, would love to hear a little bit about what your trigger is for a second rescue med. How often do you have to do it? Is it successful? So Shanna, why don't we start with you?
Sure. So I wish that I had the choice to decide if I'm going to go to a second med. Ireland always needs a cocktail immediately at onset, or like Kaylee mentioned, we know that we're going to end up in the ER and she's going to be intubated in ICU. So I think we had planned later to talk about how our rescue plan came about, but it came about in a hospital setting. And so every time Ireland seizes, she goes into a full body tonic-clonic, and she gets nasal Versed, and she gets Diastat, the rectal diazepam, and then she also gets Klonopin in her cheek. And that has worked since November. We've avoided the hospital since November. So, and she's totally sedated with all of that, but I'm scared to try anything less, to start with just one of those and see how it goes, because even with all three immediately at seizure onset, she'll still go for 18 minutes. So I did want to mention too that along with the medicine, in conjunction, we also have an oxygen concentrator and an ambu bag. Ireland does stop breathing, not because of the rescue meds, but because of the seizure. And so I bag her the whole time until she does finally take a breath. And so, let's see, I was just looking over my notes here. So yeah, because she's not breathing and it's so severe, we are very aggressive with her medications and her seizure action plan. But I do think that miraculously, with these severe seizures, she still has a structurally clean MRI. And it's my personal feeling that because of our aggressive rescue plan, in conjunction with the ambu bag and the oxygen, that is a large contributing factor to the fact that she still does have a clean MRI. So yeah, I maybe one day I'll have the choice in deciding whether or not to give more, but we hit it hard and fast at the beginning because we don't really have a choice right now.
Yeah, well, it's incredibly intense. I mean, that sounds, you know, incredibly challenging. And if you know it works, it works. I think a lot of us are hesitant to make change when things are working. But I think it's great too. You also brought up the question about breathing, because, you know, if a kid does stop breathing during seizures, I know a lot of people have trouble getting, you know, oxygen and pulse oxes and all those things. So, you know, it's something that people really can advocate for and should advocate for, and find somebody to write them a prescription as soon as they have any sense that that's going to be a problem. And then also with the administration of rescue med after rescue med, we know that there's also the potential for respiratory depression issues. So I think that's a good point to bring up. All right, Emily, can you tell us a little bit about, with Madeleine, how you guys do?
Yeah, we, similar to what Stacey and Elizabeth were speaking to a little bit out of the clonazepam and then moving to the Diastat, we try to, like everybody, it's really a decision of quality of life, I think, for us as well. In addition to, you know, stopping the seizures, the cluster, sometimes it depends on what the trigger is. And this might sound really naive, but I guess sometimes even like maybe it's wishful thinking. Like if we know something's going to be a trigger, I might give her a little Tylenol to see if that will relax her first. That's coming. Like she always seizes after a blood draw. So I might give her some Tylenol beforehand, and maybe that's not a good idea, but if anyone has some advice, stick it in the chat. But yeah, so things like that, that then we do try, if she starts clustering in the middle of the day, or it's a few hours from bedtime, that we know the diastat is going to knock her out for hours on end and ruin the rest of her day and ruin her night's sleep. We might try to do the clonazepam, see if it works. Sometimes it doesn't, sometimes it does, like Elizabeth said, you feel like you're wishing. And then move that diastat if necessary, and maybe try to make it to bedtime or something, so then she can hopefully sleep longer and not be as on the next day. So we try things like that, yeah. It's a lot of judgment calls, which are difficult.
Yeah, what are your trigger points for first and second? Like, I mean, do you have a clear marker that you utilize for kind of when to give the second round?
We don't, and I think that's something that would be helpful that we've talked about. I think we need to create, we're a family who we have some outlays of, we know what we're supposed to do with the rescue meds, but having a more clear plan of if this, then that we discuss maybe with our neurologist, I think would be helpful. But like, for example, with the clonazepam, like if we give it in a few hours later, she's still clustering really closely together, and it doesn't seem to have abated anything. But sometimes it might be able to reduce the clustering from 5 times an hour to 1 time an hour. Well, then we might ride that out for a couple hours, but then it might go back up to every 5 hours or 5 times an hour, and then maybe we would administer the diastat again and try to break the cycle. Because normally the diastat will stop their clusters for like 24 hours. So.
Right. Yeah, and I think it's, I think you bring up something that a lot of us deal with, which is that sometimes it just depends, right? Even if you do have a plan, like there are lots of things happening, and I think all of us have been through this for a really long time and have learned to start trusting our instincts, and we know that, like, okay, it feels like it's time, this is too severe, this is too scary. And so I think that was a really, empowering thing for us when we finally, been through it enough times to know, okay, we know our kid better than anybody. We know what needs to happen. And I think we're right a lot of the time. Sometimes we may not be, but I think that's, it's important for us to be able to, do what we think is best for our kids. So Elizabeth, how about you? I know Spencer, you mentioned her primary rescue meds fail like 25% of the time, 25%, something like that. So what do you guys do? What's your trigger for the second line rescues?
Well, I had sort of worked out with her epileptologist that 3 seizures within a cluster then will require rescue meds. And I think we'll talk a little bit more about that down the road, what defines a cluster. But sometimes after 2, I will just lay with her because it's in the middle of the night and just swipe her magnet, for like half an hour. And I'm not certain that that's effective to stop the 3rd, but anything to not give those rescue meds, to have that 3rd. So sometimes she does not have the 3rd. And so magically it has to be the VNS, in my staying up with her. But there are times where I do give it after a cluster of 3, and then she'll continue. And then after the 4th one, I'll think, I don't want to go to the hospital. Let's just see if it'll stop, And so there's been times like that where I'll give the rescue med, she'll seize again, but then she'll stop, and I just got lucky. Mm-hmm. So I really don't know what happens. It's what an issue has been for me, though, with the nasal midazolam is that since it's new on the market, it's brand name, it's expensive, and so I've had such a battle with the insurance company for refilling it soon enough for the next round. So I've been rationing her dosage, just hoping that I'll have enough until the next refill can come in. So that's been an issue.
Yeah, it's upsetting to think that that's the way our healthcare system works. But yeah, thanks, Elizabeth. Does anybody have anything else to add about second line seizure rescue? Okay. We're going to move on now to talking about whether there are clear enough precursors for status epilepticus or clusters for your child that you developed a proactive approach to administering meds to try to prevent your child going into status epilepticus. you know, they're, I know we've talked about some people, if a period's coming on, they'll do an increased abridging or of, you know, a seizure med that they're already on to give a little bit of a higher dose to kind of break or to hopefully, you know, protect against those breakthrough seizures. So, Kaylee, I know that you guys have a plan. If you could let us know.
So we talked about clusters, and that's usually like our first trigger. We know something's coming. And then I'm glad Elizabeth mentioned the VNS, because that, since we've had that surgery, that's definitely like our, I don't know if it's considered a rescue medication, but that is definitely our first line of defense going forward. So initially what would happen is we can see something's coming. We see that these clusters are increasing. So we're going to start with that VNS. And personally, I usually give that like good 3 swipes before I move on to my next rescue medication. From there, we had talked about I would administer the clonazepam and pray that that worked. And then by the time, if I needed to get to diastat, that's kind of where I would stop. I would give the diastat. I've never repeated a dose of that because I usually have had, he's pretty out of sorts by then. So if things didn't work or that didn't stop the seizures, we would end up in the emergency room because I was just too afraid that I was going to over-drug him or hurt him or make something worse.
Right, right. Yeah, and I think it's great to talk a little bit about VNS. So does anybody else have VNS? We know Spencer's got, Dylan's got. No, not yet. Yeah, I mean, it's something that, I don't know if they, yeah, like you said, they really classify it as a rescue, but I think that's kind of what it does. So it's a really important one to bring up. And I know we're talking about it, and hopefully other people are having conversations with their providers, because it's great to have something that's not a drug that you're putting your kid through another drug on top of the drugs they already take. So Shanna, what about you? You talked a little bit about this, but yeah, you want to share what you do with Ireland?
Well, so monitoring her is really key because we have to catch it at the beginning. So she doesn't really have, we don't really have any sort of warning. She doesn't have triggers. It does happen more often at night, like Stacy was saying, right after she goes to sleep or early morning hours. So I think the key for us is catching it immediately, because it does. It starts focal and then it's full body tonic-clonic, and so it's really key for us to monitor her closely during the day. Of course, we watch her like a hawk, and then at night she sleeps with a pulse ox monitor on, and that acts as our seizure alarm because she stops breathing and desats and it goes off. So as far as preventing status, it's really key that we hit her hard and fast immediately with her rescue drugs. And like I said, it's been working. So, so yeah, close eye on her, getting them at the beginning, and that's been working.
Mm-hmm. Does anybody else have anything that they do, any kind of bridging or kind of precursors that they know of to try to, treat in advance? And I think, Emily, you mentioned that you sometimes will even just use Tylenol as a way to ward off potential seizures.
We don't. I like this idea of bridging, but it's not something we broach with our doctor. So some of these webinars have been helpful for me. That's one of the ideas that I've written down that I'd like to discuss with our epileptologist. But yeah, one of the things that I do is just Tylenol. I feel like so often I think we forget about when these kids are on such serious medications, they're not, like our daughter is nonverbal, she's not able to communicate her pain and things like that, that even thinking maybe some of this discomfort or things that we're not able to identify. So again, that's something small that we do that, but we don't have any like formal plans, but that's something that I would like to work into our seizure action plan as we work on it.
Yeah, absolutely. Those are great points. I mean, the same with my kid, Elliot, just, they can't tell us what's going on. So we're always trying to guess. Yeah. And I think specifically, you know, we know that there are some conditions where there are seizures that are triggered by fever. So I know a number of people who, as soon as they see a fever, they'll start, you know, giving Tylenol or so. Something to keep in mind. Great. Okay, we're going to move on to seizure emergency plans. So I guess I want to hear a little bit about what kind of plans people have. We know a lot of people have to make them for school. You know, do you have them maybe for if somebody else is at home doing caregiving for your child, or you know, do you, and how was it developed? Was it developed with your doctor, or do you just kind of say, this is what works, this is what we're doing? And do you kind of feel like your plan is working? Is it sufficient? You know, in different areas, if you call, you know, 911, is there anything in there that's useful? If you're at the hospital, you know, those kinds of things, you feel like it's up to par. So, Stacy, you want to tell us a little bit about your plan?
Sure. I had actually forgotten about my plan until you requested. You had requested it. But looking over it, it was probably made maybe 5 years ago, but it's still good for today. Our plan was trial and error. Really, we had to go through all the different types of seizures and meds, and you know, figuring out when she seizes, how she seizes, what do we see, what does it look like, and really it's just step by step. Hey, this is what the seizure looks like. Even going back to the previous discussion about what might trigger, I think it was the, I'm so sorry, the precursors you were mentioning and I mentioned, I think to you when we spoke, that sometimes actually, don't laugh, but a full moon. When a full moon is coming, or there's something, and she has a lot of maladaptive behaviors, we know that we have to keep an eye on her, because we don't, that's, and also a sign where we notice that things are more than likely to happen. So we're constantly checking on her. But we know what to do just from years of doing it. And thankfully, I don't want to put this out there, but it hasn't shifted since she started with the tonic-clonics and going into maybe 12 years old, 11 years old, and puberty is a huge game changer. Her seizures are now shorter but more intense. But everything that she goes through is outlined in that plan. This is what it looks like. This is what you should do. She might turn dusky, meaning she might not be getting breath or air. And sometimes if that goes on too long, you know, definitely administer the meds almost immediately. But lately she's been stopping on her own. She's gone through the clonic stage, and she goes into postictal. It's pretty short. It's not long. So we've been blessed with that. It's been short but hard seizures. And anybody who watches her, as far as babysitting for us, they've known her for a long time. So they also know what to do. I don't even need to give them that plan. Like I said, I didn't even have it at the ready until you asked for it. But we have a small community, and they know her. They know what to do. If we're in church, we have beepers. Something happens, they beep us immediately, and we just get up, embarrass ourselves, and run down to where she's at. I'm so sorry.
Yeah, no, that's great. I mean, did you develop with the doctor?
No.
Okay.
No, we've done everything pretty much on our own. We've been, you know, we've been guided. You know what? I don't even think any of her neurologists or epileptologists has ever told us, make a plan, make a seizure plan. It's something that you pick up from the community, from the mommy community, that we all exchanged ideas, and that's, I think, where we get most of our knowledge from and our information. Like Elizabeth, you just mentioned, previously the nasal spray. I'm like, wow. And then the Ambubag? Great. I just picked up 2 ideas that I had no idea about. So thank you, ladies.
Wealth of knowledge with this group. Yeah.
It's unbelievable, but it's how we have to figure it out a lot on our own, trial and error, and just being very aware of their surroundings, and just it's a fluid situation. The plan is just a fluid situation.
Absolutely. Absolutely. Yeah. Kaylee, what about your plan? What kind of plan do you have? How many for different scenarios, or are you happy with it?
Well, I actually need this webinar series. We're pretty proactive about discussing things with our neurologists, especially we're in our teen years. So there's a lot of hormonal changes. So we're constantly updating our approaches towards things. But on the other hand, I don't have anything in writing. So heaven forbid something happened to me and someone else had to take care of him, they would just be lost at sea and have no idea what to do.
Yeah. It's incredible. I mean, we also don't have anything formal, but I was really hit hard. We spoke with another person for the Rescue Med series she's a single mom. She got COVID in the hospital on a ventilator, cannot be consulted. She had a book and her family stepped in and it's phenomenal. Yeah. So it's like, she's incredible. And I think we need, we need stuff like that.
For guidance on this.
Exactly. Yeah. It's a pretty scary thought. So Emily, what about you?
Yeah, I would say have a little bit of guidance written down, but not as much as I would like Kaylee. One of the issues that we've really had that I would love if there's other people listening or if any of the other moms on here have suggestions about is we did have to fill out formal documents when Madeleine started attending public school when she went to preschool last year. And we had a really hard time with that because she has different types of seizures. They look different. Some of them we wouldn't administer rescue drugs for. We know she's going to come out on, but she does have a type of episode that lasts 10 to 20 minutes sometimes. We don't think it's status. It doesn't show on an EEG. It's really confusing. As you guys can understand, this stuff evolves. So she had one of those episodes at school where I think I probably wouldn't have administered anything. They administered the meds, and the policy at our public school was they immediately, if they couldn't contact me and I couldn't beat the ambulance to the school, she got in the ambulance and had to go to the ER. And so we had ER trips to the hospital because of that. So I don't know if anybody has advice on that. And that's something that we've talked to our neurologist about. Okay, how else, because he has to also help fill out those forms for the school and sign off on them. And he tried to sort of explain to them the difference, but the teacher and the aides in the classroom are not going to make those tough decisions. They're going to err on the side of caution, which is also why we give them the rescue meds. But if anybody has input on that, I would appreciate it. That's something that we're really struggling with and want to add into, not only for caregivers and people at home, but when our children do hopefully someday go back to school in person, how do we be prepared for that?
Right. And I think you had mentioned also that you kind of felt like you didn't really have a seizure plan, but your doctor said, oh no, we have a plan, which I think is so
yeah. So after we started the series, I mentioned that we were participating to our epileptologist, and he said, well, we have a plan, and we do have guidelines from him for when to administer the diastat, but it's a few sentences, and I feel like those would be hard decisions to make for our family and for us even sometimes, that I think having a formal, more laid out plan would benefit everyone. So I also found that interesting, that just that the perspective of the provider as well, that they're like, oh, well, when you're supposed to give this, isn't that sufficient enough of a plan? That I can see how a more thoughtful, comprehensive plan would be helpful. And especially in the days of COVID, of what if something happens to me and somebody else needs to be making those decisions all of a sudden.
Yeah, no, that's so important. I see lots of nodding heads there. Yeah, go ahead, Jen.
Oh, I was just going to weigh in on the school thing. No, I really think that you can put anything into an IEP. and you can have it in the school in her IEP that at minute 3 or whatever, they call you and let you know, and then you guide them as to what to do. So they will call the parent before at minute 3, and then at minute 5 or whatever, they'll call 911, or they'll administer the rescue meds, so that you don't always have to be dealing with the ER and having them taking, I don't know how close you are to the school, but if you can get over there before the ambulance does, then you can just, say, have it put into the IEP, because there's a difference between policies and laws. And, the IEP being a legal document, you can have something that guides them as to what they're supposed to do before they go to their school policy, which is just to, call 911. You can sort of sort of nip that one in the bud a little.
Yeah, I appreciate that. Yeah, they couldn't get a hold of me one of the times, and that was part of the problem. A lot of the times I could get there pretty quickly, but she'll be moving as she's a rising kindergartner, so she will be moving to a further away school. But Shanna was just saying, have them try to FaceTime you. I think that's good advice. Also to consider, I did sign something saying that the teacher could film her so that I could confirm like what actually happened. So we tried to do some of those things, but I think some of it too is the teacher and the aide's comfort level and stuff. But I appreciate that, Jen. That's a good idea.
Yeah, no, because you don't have to always be dealing with that.
Yeah, it's a lot of ER visits. So speaking of hospitals, we wanted to hear some about people's experiences, kind of when you've had to call 911, you have EMTs in the house, or, and you're in the ER, or you're inpatient and dealing with hospital staff, and how kind of, you're up against people who aren't listening, or, to what you're saying. So we have a couple of people who've been in that place. I know, Elizabeth, you had an experience when you were Spencer inpatient.
Yeah, I've had to go a couple times in the last few months. In March, she was clustering through the night, and the rescue med didn't help, and then she went into status, and so that was a 3 a.m. ambulance call. And then in May, we were in the ER again, and she was seizing, and the ER doctor really trusted me, and I said, give her something. And so she gave her a teeny bit of Ativan just to be cautious. You can always give more. They got her up to the floor, and that's where the issue is the definition of clusters. And I know on the package insert for the nasal midazolam, it says within 24 hours, like 3 seizures in 24 hours. And with her epileptologist, he recommends 3 seizures in 12 hours. And so I was talking, and all of that's great. It's different for everyone. And the neurologist on the floor, who wasn't familiar with Spencer, I kept saying, give her something, just because she had that little bit of Ativan in the ER, that's nothing. And he wouldn't, because he said, no, the definition is 3 tonic-clonics in 15 minutes. And this had been going on all night. And so it was there's no standard definition, which maybe there should be, but maybe it's great there isn't. And so I just wasn't being heard, the caregiver's voice. So that was difficult.
Mm-hmm. Yeah, and it speaks to, how critical it is to maybe have plans that also entail when you're inpatient, if, potentially, or in the ED, that, that has something from your doctor that says, this is what works for this kid.
Yeah.
And Stacy, I know you've had another experience, which is terrible, but yeah, please.
Yeah, I'll try and be quick. There's so many moving parts to what happened to Amanda. So I apologize. If I go long, cut me off. Amanda, she was diagnosed also with moderate sleep apnea back in 2017. And the best way to cure that was take the tonsils out. So we scheduled a tonsillectomy. I pushed for having her stay overnight in All Children's Hospital up here in St. Pete. And it's a good thing I did. She went through the surgery, 15 minutes, in and out, great. But I was told by the nurse the night before, or the late afternoon before, she can't have anything to eat after 12 o'clock, nothing, you know, she's going under anesthesia, whatnot. And it for some reason, it didn't all click to me. And I'm trying to give her her meds, her sprinkles, her Developmental X, her crushed up 2 or 3 other, you know, pills. And she had to take that for her meds because she has it in the morning and the night. And I'm talking to this woman in the morning, the nurse, the surgeon nurse, the surgery nurse, and well, you can't give it to her with yogurt because that's how she takes her meds. Well, I'm like, well, how am I going to give it to her? Well, maybe just, you know, mix it up in some water and let her sip it through a straw. And I'm like, clearly you don't understand, and you don't have a child who has seizures, or an autistic child who's nonverbal. But I did the best I could. I took some apple juice, whatnot, had her take what she needed to take through the straw, get to the hospital, and go ahead. We went into surgery. Like everything went well. We were in the room for the rest of the night. It was fine. The following morning, around 6:30, she had a big seizure. Okay, great. Nobody was there. Basically, I took out my diastat, did what I had to do, and her seizure calmed down. Then I find out that the anesthesia and the anesthesiologist really didn't sit down or I didn't find out. I just thought backwards, and I thought, you know, I really hadn't been informed by the anesthesiologist what the pros and the cons were for a child with epilepsy to go under anesthesia. She'd been under anesthesia before for dental work. It was different. She came out of it beautifully, no problems, numerous times. But this, I was told, was different. Never had a consult with the anesthesiologist. If your child has seizures and they have to have surgery, you better make sure that you have an anesthesiology consult and you go through everything with that anesthesiologist, because you don't want to go what we went through. Go through what we went through. So bottom line, she sees, okay, I took care of that seizure. Well, later on that same day, in the middle of the day, towards the end, she was just laying in my lap because she was taking a little nap. She started her seizure. Mm-hmm. Then she kind of went out. Then she started another, and we had more clusters and seizures. And I'm screaming for somebody to help us. Nobody showed up. And I've got this heavy child. I struggled to get her to her bed, screaming. Somebody passed by. They saw me, but they didn't come in. Anyway, somebody did hear us, hit the stat, I guess code blue, and everybody came swarming in. Bottom line, she continued to seize. They couldn't stop her seizures. She was hooked up to the what do you call it? She was hooked up to the IV machine. She was given her Depakote. She was given her oh my gosh, look, I'm forgetting names of things because we haven't had them in so long. There was another medication, such as the V. Gosh, anyway, yeah. And that clued me in right there. Hey, that's the same thing I gave her in the morning. And then it dawned on me, why couldn't you all bring her in the night before? Administered her meds. If this anesthesia was going to be such a difficult thing, lower her seizure threshold, just one comedy of errors, and really not a comedy, but all these things, they had to put her in a coma. They had to put her in a semi-coma to go ahead and give her brain a rest. We were so scared. We called her pastor. We called our children's pastor to get on over here and pray over this child, because we thought that was it. Forget it. I have only seen my husband cry a handful of times over the 20 years that we've known each other. And I tell you, he was crying over her. And so many things just went wrong with the way they handled the situation that I didn't even have my plan.
Mm.
So many things you realize after the fact. She did finally 3 days later wake up on her own.
Mm. Yeah, but it's really, it speaks to not only having that anesthesia consult, but having that anesthesiologist talk to the epileptologist, right? Let's have some coordinated care here.
Absolutely.
Outrageous.
Absolutely. If
Yeah.
there's one thing that we learned out of that was to definitely get with that anesthesiologist come heck or high water,
Right.
because we did not know the extent of her receiving that anesthesia. Maybe there could have been something else, or we could have brought her in the night before and you know,
Right.
just filled her up with Depakote and the other medication that starts with a V. But
Right.
it's just awful.
Yeah, no, absolutely. I mean, we didn't really get into this too much, but does anybody have experiences with non-convulsive status at all, and how you manage that and what that looks like, Elizabeth? Yeah.
She's only gone through it about 4 times, and twice it took intervention at the hospital, and then the other 2 times she miraculously came out of it on her own at home.
Mm-hmm.
So I don't have that much experience like Shanna. Shanna, you do.
Yeah. Okay. Anybody else have thoughts on non-convulsive status? Okay. Well, we're coming towards the end here, but we want to go around one more time and kind of have each of you share your wisdom with all of us about kind of what you would love other parents to know, and, you know, about how you were able to maximize your seizure plans, or your effectiveness in controlling seizures. What do you think all of us DEE parents need to know? All right, Kaylee, I'll start with you.
Put me on the spot here. I think it's just important to realize that your child is unique. So just make sure you're talking to your epileptologist and your team. I think it's definitely like a team effort putting something like this together. Yeah.
Yeah, and I think you're a great model. I mean, I know that you said that every 3 months you talk.
Yeah, I wish I was more proactive on having things written down, but I'm hoping after this next webinar, I'll be able to get some of that in writing.
Yeah.
But we do talk to ours very frequently. Again, Dylan's like in teenage years, so there's constantly hormonal changes and stuff going on. But even when he was younger, you know, we were seeing the doctors pretty frequently and always trying to see what our next move was or how we can adjust things to kind of make his quality of life a little bit better.
Excellent. Yeah. Shanna, what are your words of wisdom for all of us?
I have 2, and I'll try to be quick with them. First of all, if your at-home meds are not working, ask for more or different meds. Don't keep, you know, going back to the hospital if your rescue meds are failing. You know, don't be afraid to have that conversation, because sometimes, I don't know why they don't bring it up, but you know, your doctor may not. And then the other thing, so having a seizure action plan written down is great, but in the middle of an emergency, you may forget it because this has happened to us. And so we've ended up in the ER, and our seizure action plan includes a plan when she's on the trauma table, because certain meds work better than others once she's at that point. And so this happened enough that, and we forgot it a couple of times. So the hospital was like, well, we can put it in her chart so that it comes up as soon as she's, you know, here in the ER. And so then I didn't have to worry about forgetting it each time, because it's like, you know, you're in crisis mode, and it's laminated and it's ready to go, and we left it at home. So the fact that it's there at the hospital and it just pulls up right when they pull up her chart, it has been helpful.
Yeah, those are fantastic pieces of advice. We try to keep the updated list of all the meds and everything, and Elliot has a go bag. It's like all the key stuff is always in there and sits in the closet waiting, and it's like just one way to try to minimize the things we forget. Emily.
Yeah, I think in addition to what you ladies just said, you said talking to your doctors, like having a good doctor We switched early on. We had a neurologist who thought Madeleine, like, we hadn't had a genetic diagnosis yet. He thought, oh, maybe she's outgrowing her seizures and she had reflux. He was totally wrong. He was being very optimistic. We found a better provider. We found someone we're very comfortable with, someone we can have these hard conversations with, and just really trusting yourself and trusting your instinct. So much of what we've heard from everyone today is about trusting our own experience and talking to other parents who have experience. And I think that's really important too. I would recommend that.
Yeah, absolutely. Yeah, no, we also had that experience early on. At one doctor, we took my son to see his first neurologist, and she put him on Keppra, and she saw him once and then just kept upping it through phone calls for months and months and months and months, and it clearly wasn't working, and she had no initiative to say, well, let's think of something else, or anyway, finding somebody new. And I think, Elizabeth, you have something kind of along these lines that I think is some great advice as well.
It's exactly what you all have been saying is don't be afraid to be aggressive. And I needed to learn that lesson. A few years ago, I found a new epileptologist where previously we'd just been spinning our wheels and the doctor was giving up. And the new guy says, let's try this, we'll do anything. And so that was a game changer. She's not doing that well, but at least there's the next thing on the horizon. Right.
And I loved that you were proactive in seeking out somebody who really had expertise, right? And you said you drive about 6 hours to do.
I do. It's actually about 8 hours. I drive to from St. Louis to Ohio every 2 or 3 months, and it's totally worth it. I'd drive further if I needed to. He's that much of an inspiration.
Mm-hmm. That's incredible. Hopefully you can have some telehealth visits soon.
Yeah.
We'll see.
Mm-hmm.
Okay, and Stacy?
Well, I think I just ran through the importance of consultations, dentist, surgeon, whoever, just the importance of getting everybody on the same page. But sometimes you have to go through things before you can really think of what you need to talk about next time, if that makes sense. Like the issue with the anesthesia and the lower threshold, the lower seizure threshold, that was huge for me. That'll never happen again. You know, you learn your lessons, you alter your plan, you update it, and you gain knowledge, and you share that with other people so they don't have to go through what you went through. Also, I think the doctor, Elizabeth, how you drive like that, absolutely. We drive just about an hour, so we're lucky. But finding a doctor who's willing to go out of the box to really find what works best for your kiddo, or even why what's happening is happening. And we found that doctor here. He's in Lakeland, and we love him. He's a little cuckoo, but sorry. But he's awesome. He's great. He's a younger guy. He's actually the one who was able to gear us towards Miami Children's Hospital for Amanda's diagnosis of SCN2A mutation. And I would have just been thinking, I don't think autism and epilepsy are her main diagnoses. That's not, those are symptoms.
Right.
And they are. And it's,
right. And having providers who are willing to look at the full picture and help you ask key questions that need to be asked. Yeah. Yes. Well, we're a little bit over time because we were very ambitious, but I think it was really a spectacular conversation. If there are any questions at all, please feel free to type them in. I think the range of things we discussed was really an incredible overview of how differently our kids can present and react and respond to different meds. And, I love in all these conversations that we've had, we did about 20 interviews. It was really powerful to hear how parents were empowered to really, push for change. I think, Shanna, we didn't get to it, but that, when you were inpatient and you demanded, you said, I'm not leaving until I have a plan. I loved that. And it's like, that's you know, our children often don't have a voice, and so we need to be it for them and demand the best for them. So I'm really honored to have been able to hear all of your stories. So yeah, Jen.
No, I just want to thank everybody for sharing these stories, because I found I got a lot out of all of them. And the one thing that I'm really the most pleased by, I guess, is that people aren't really beating themselves up too much. It sounded like you guys faced a lot of things, we all have, and you took that information and learned from it and moved on. And I think the whole reason for having this series is so that we can all start getting these seizure emergency plans. And I think one of the first responses that a lot of us had were we felt a little guilty about the fact that, well, actually, I don't have one. And I think that look at everybody. Most of us don't. And that's why we need a series like this. So I'm really happy that for those of you who do and you're really on it, I'm so glad that you've been able to share that with the rest of us who need to get either get one going or just make some improvements to the one that we already have. So thanks again, everybody, for being part of this.
Yeah, absolutely. And it's all, you know, we'll all get there when we can get there. And hopefully, you know, we have the fourth webinar in our series is August 12th. Actually, I can pull it up. And in that, during that webinar, we will be hearing kind of from a range of folks about, excuse me, sorry, I'm trying to pull up this slide, which, there we go. So this webinar will kind of help us. Well, Jen, why don't you explain it since you're planning it? You'll probably be able to give.
Well, it's exactly what it says. We're going to design our own plans, and we have a template that we're working on that that we're hopefully going to be able to work through it. This will be like a workshop. We'll all be able to. We'll have a number of caregivers, myself included. I mean, I work for the LGS Foundation. I'm also the mother of an 18-year-old with LGS. So we all have our own experiences, and I'm going to be building my own right along with all of you. I'll have done it a little bit ahead of time so that I have something to offer. But I really think that this is the cherry on top of everything that we've been talking about for the last 4 weeks.
Absolutely. No, I'm really excited.
4 weeks or more, actually 6 weeks, I guess, in total since we started.
Right. Yeah, I'm really looking forward to it. And I love the fact that it's going to be peer-led by parents who have done this, who know what we're going through, you know, who know all of the question marks and the what ifs and the ands and around all of this. So that'll be really fantastic. We also have a webinar next week on autonomic dysfunction, which I'm really looking forward to because I think there are a lot of answers that potentially lie with autonomic dysfunction, you know, around behaviors or things that are going on with our kids that we just can't quite find an answer to. I've been told. So I'm looking forward to seeing if maybe some of the things that were the behaviors, the things that we're seeing might have something to do with autonomic dysfunction. So, and we had a great webinar on Monday about telehealth. I know we talked a little bit about that. I brought that up, but if any of you are, have had telehealth appointments and benefited from it, it's something that potentially could go away. So just some actions we can all take to try to make that stick around for families who have a hard time getting out of the house, even when there's not a pandemic, like all of us. So thank you again for joining us. And we want to thank again our sponsors, Norellis and UCB, who helped make this series possible. We look forward to seeing you again on the next webinar, and everybody stay safe.
And just one more reminder, it's seizure emergency plan. We changed it from seizure action plan.
Thank you. Right, seizure emergency
you think
plan.
IEP, just think ISEP, another acronym for everybody.
Right, individualized seizure emergency.
Right.
Thank you for that note, Jen.
Yeah, okay.
Thanks, everybody. Take care.
Thanks, guys.